Welcome, everybody, to the Critical Care Obstetrics Podcast. I'm Dr. Stephanie Martin, and I'm here today with my partner, Dr. Suzanne McMurtry Baird. I'm the medical director at Clinical Concepts in Obstetrics, and Suzanne is our nursing director. And we're going to be talking about something a little interesting today that a lot of you guys have actually been asking us to talk about. We do lecture in real time about this on a lot. We really haven't done a lot of podcasting on it. And this is going to have more of a medical legal focus. We do talk about medical legal stuff in our Patreon. If you guys are interested in this, we do a lot more of this on our Patreon channel. That's patreon.com/CCOB. But today we called this one, The Chart Will Be Read in Court. Because it will.
Mm-hmm. Yeah,
it will. If it gets to court, if there's a bad outcome and it makes it to court, it's going to get read in court. And we want you guys to be doing what you can to make your life easier, hopefully avoid a medical legal situation, or at least making it to trial if possible. So we're going to be talking about some tips and things that you need to understand about how to document.
Yeah. And it just as a overall, I just thinking about documentation, and does it really tell your story as we go through this? If you were to look back at your documentation for any patient, but let's say it's a high-risk patient who you're doing all kinds of assessments and everything, would it reflect how you cared for that patient? And that's for nurses and physicians.
And I mean, we can tell you the answer is most of the time it does not.
Right.
Because we review a lot of charts for a variety of reasons, medical legal reasons, other reasons. And it is extremely difficult to figure out what actually happened to the patient. I will say that Epic does not make it easy to do that. It is very challenging, but it is shockingly difficult to understand what happened to a patient in hindsight. It takes hours of reconstructing vital signs, documentation, chart notes, fetal heart rate tracings, all of those things to really understand what actually happened. And even then there are gaps. But it all starts with the things that you write.
Right.
Or don't write.
And it's where we go to first.
Yes.
I mean, when you're looking back on what care was provided to the patient, we always turn to the documentation that you provided as a reflection of how that care was done. And like Stephanie said, oftentimes it's just not there, or it doesn't tell the picture, or it's fragmented, or you have a lot of extraneous crap in the EMR that you've been told you had to complete. Like literally see a lot of documentation on the patient's body image. My body image when I was pregnant was not great, or postpartum, but here you have this high-risk patient that's hemorrhaged or something, and you can't figure out how care is provided, but the documentation on body image is there. Really?
Yeah, don't get me started on the hemorrhage documentation. But we'll talk about that.
We will talk about that for sure. Has to be. You have to talk about that.
But, so you really have to think about, your documentation is everything is a potential legal exhibit. Literally everything, including your text messages, whether it's your personal phone or any kind of communication device that's been provided by the hospital. All of these are potential exhibits. And if you understand that, and think about it in those terms, like who could be reading this? Does this adequately reflect what's actually happening at this moment in time? That's going to be very, very helpful. But the hard part is that we have to balance that with actually caring for the patient. Like your notes and your documentation are also a tool that communicates from shift to shift, provider to provider. And it can be challenging and incredibly time-consuming to do both. Now, the EHRs have also tried to make our lives easier, and in many ways it has, and in many ways it's made our lives more difficult. One of the ways it's made it more difficult is that we kind of joke that the progress notes in particular look like ransom notes because it's just cut and pasted from other people's notes without ensuring that it's actually accurately reflecting what's taking place. And it's not okay. Like if you're a couple of years later looking at that note and you're going, well, that was just pasted from the other note. That wasn't actually what happened. Well, then what are we believing? What can we believe in any of the
Right.
documentation if
I
that's
read
not
one.
correct?
I know. I read one the other day where it was a scripted note that was a cut and paste,
Mm-hmm.
and they didn't fill in the blanks. So it had these asterisks there waiting for that person. I think it was a physician progress note to fill in the blanks. Like her hematocrit went from, asterisks to asterisks. This was a postpartum note based upon EBL of asterisks. I mean, that's just, how can you explain that? I mean, and they read that to the jury, and the jury's like, they didn't take the time to do that? Like,
Yeah.
really fill it in.
So how do we believe anything in the note? Did they write it? Did they read it? Is that the note template they intended to use? Like if they didn't even look at it, it's really hard you can see how that really impacts credibility.
Right.
Right.
Yeah. And we're not trying to make everybody afraid of documentation. Let's just say that too.
Yeah, no.
Before we get in some of these examples, we don't want everybody to be like, oh, I'm freaking out. But at the same time, we've really got to start looking at our documentation to say, is it accurately reflecting my care? Because I'm just going to say, like we said, it's just usually not.
Yep. Yeah. I mean, we don't want you to be scared. We just want you to be thoughtful. And remember, a jury could be looking at this. But even before it gets to a jury, your documentation can stop a case in its tracks.
Yes.
I mean, I had one of those recently where I was asked to review a case for a plaintiff where there was a bad outcome, and I reviewed the case, and the documentation was so good and so thorough in terms of what they were thinking, the differential diagnoses, the plans of care that were considered, the ones that weren't pursued and why, and the ones that were pursued and why, and all of those things. So that made my professional opinion was there's no case here, because I know I don't have to go, the attorney doesn't have to take them to deposition to understand what happened and get their thought processes. It literally, from my perspective, stopped the case in its tracks. Now they could go potentially find another expert who disagrees with me, but that's how it works.
Yeah. So that's a warm, fuzzy feeling, isn't it?
I was so proud of the team. Even though I'm reviewing it for the plaintiff attorney, my job is to give them my professional advice, and tell them what they need to hear, not what they want to hear. That's how I view it.
Absolutely.
It's the truth. It's from my perspective as an expert, it's the truth as I view it. And, in my opinion on the care that was provided, but I base those opinions when you're starting on the documentation.
Right. I mean, and that's because we're not there, right? So as you're reading this, and if it tells the story, and it tells the story that you complied with the standard of care, case done.
Right.
If it doesn't, how it would, progress is the plaintiff attorney would then go to the next stage. And that is usually getting the deposition of the clinicians that were at the bedside and trying to recreate the care that they provided, because it's not in the documentation.
Right. I mean, if you have bad documentation, it doesn't mean you gave bad care.
Right.
But it means if they're going to pursue a case, they're going to have to go to a deeper and deeper stages, like depositions of many people, in order to understand whether good or bad care was provided. And that's your documentation can avoid that potentially.
Right. Because the deposition could go lots of different directions, and it's, in other words, it's not going to be a deposition just focused on your documentation.
No, it's going to be focused on a whole bunch of things, and it's not comfortable for anybody except the attorneys. Even us as experts, depositions are not fun. Nobody likes doing a deposition. They can be interesting, but they're high stakes. It's like being in court. It's just not a jury present. So
Right.
it's mentally taxing. It's, the stakes are high. It matters to everybody in that room what's happening. And so, as an expert, it doesn't impact us directly because it's not our family member or my practice, but the stakes
Or
are
my
high, and
case.
or your case, and we feel it very, we take it on, a lot of it.
Right. And then it will go to trial,
Mhm.
possibly. Most cases don't go to trial, but if it
Mm.
goes to trial, then your chart will be put
Mhm.
up on a big screen for the jury to read.
Mhm.
And so, really, your documentation becomes so important at every stage of a case.
Mhm.
Um, and and it is so essential if it becomes a legal issue.
So, to be clear, we're not attorneys. Never have been, never will be.
Never will be.
We have something to offer from our own experience and perspective as caregivers, as medical legal experts. And so we just wanted to kind of share some of those perspectives and share a lot of the questions that we get asked when we're in person giving lectures, et cetera. So, Suzanne, you want to talk a little bit about like what a legal timeline looks like, particularly when it comes like with documentation?
Yeah. So the first thing that will happen is if a suit is going to be filed, they notify that one might be, and so there may be some preliminary activity that a plaintiff's attorney and team would do prior to even filing suit. And if they file suit, then they will file a complaint, and the complaint will outline the deviations in standard of care that they feel at that time occurred. And oftentimes, even before they do that, they may have the files reviewed by an expert in the field that in which they practice or teach, and to get some kind of idea. That may be done outside of their firm, or it may be done within their firm, depending on how large the firm is. And then they're going to subpoena the medical records, and then they'll have possibly even expert review outside of that. So in other words, some states define it where before you can even file a complaint, it has to be reviewed by an expert, and they have to do an affidavit saying that there's some kind of violation of the standard of care at
Mhm.
that point. But that expert may be used for further review, or they may get a different expert depending. Again, it may be outside sources. Then, after that is reviewed, sometimes cases again will end at that point, period, because of what's documented or what's done. But oftentimes they go to deposition, then to trial. And again, the documentation is going to be reviewed at each one of those stages. And that
Yeah,
may take years.
years. That's what I was about to say. This is not a process that takes months. This is a process that takes
Right.
years.
Years and years. And again, you may have a case that you're reviewing documentation on from 20 years ago,
Yeah,
depending on the state.
and I think, and that's what makes you OB particularly unique,
Mhm.
because it could be, the issues that are being claimed may not show themselves for years after birth. That doesn't necessarily mean that they're caused by the birth, but the issues may develop many years later that then the family decides they want to explore whether they were caused by the birth, and now we're in a lawsuit. And I wanted to highlight here, we got asked a question recently that was really interesting, um, and that is, anybody can sue for anything. Okay. That's the beauty and the dangers of the system in the United States. When you have a known adverse outcome, the likelihood of a suit is increased, but it doesn't mean that there will be a suit. And there are lots of things that influence families and patients' desire to pursue a lawsuit in obstetrics. Some of it is due to the outcome, some of it is due to the experience. It could be a combination of both. If they don't feel like they're getting answers, whatever it may be. But in the United States, plaintiff attorneys will take the case if they think there's an opportunity to get money out of the case. Okay, because you don't have to have money to file a suit. You have to have money to defend yourself in a suit, but you don't have to have money to file a suit. Plaintiffs' attorneys take cases on contingency, so they get a portion of whatever the judgment is, whether it's a settlement or a trial award. So anyone at any income level, there are really no barriers to taking a case except finding an attorney who will take the case. And then whether the attorney takes the case or not is based on their own evaluation with their experts of the merits of the case and the likelihood of getting a financial award to warrant their financial investment.
Right. And OB is a high litigious environment that we work in, neonatal as well. And so I think having reviewed charts for a number of years, I think one of the biggest things that I'm asked as an expert is, do you believe if it wasn't charted, it wasn't done? It probably most cases you're asked that. And my response always is no, I don't believe that. There are a lot of things, for instance, that we assess that we do not document. There are a lot of things that we do not document. Think about it. I walk in and, I may assess the room, for instance. I may assess who's in there. I may assess where they're standing. I may assess something with the patient and not necessarily document it. See that all the time. Think of shoulder dystocia. I don't routinely see where people are standing around the patient during a shoulder dystocia. But yet you're going to be asked in deposition who was standing where, on what side. Sometimes you'll have an attorney ask you to draw a picture of where people are standing. Now, it may be one of those cases where you remember the patient's name and you in your mind can develop that, you can draw it out, right?
You have the image.
The image, right? But that's probably going to be an unusual, very high stress situation in which you do have that you've locked in. You may remember what you were wearing. You may remember exactly who everybody was or what they looked like even, but it's not documented, right? So that's an example of how that might be used in a case.
But you have to document the things that matter.
Right.
So when I'm reviewing an RRT response and I don't see any documentation of airway management, I'm going to assume that it wasn't done because that's such a key part of a rapid response, where particularly if there's a respiratory component to the rapid response. And I can think of several situations where this is the case. So now we've got to go into deposition for somebody to convince me that or convince the attorneys that, it was in fact done and here's how you can know it and, whatever. And other people are corroborating that story. But if people can't corroborate it, if the nurses are like, well, we always have problem with this person. And
yeah, that's when I said depositions can go any direction.
Exactly.
And then you get some, feedback that you weren't really wanting to come out.
So you have to document the things that are important in the situation.
Mm-hmm.
But it's not reasonable nor expected that you're going to document every single occurrence in every patient's hospital course.
Right. So just because it wasn't documented doesn't mean it wasn't done. But
Right.
The key point that we want you to take away from that statement, because it will be asked every single time, is does your, again, documentation reflect the care that you provided? Period.
Mm-hmm.
I mean, again,
Right.
What's the important components that you must chart?
Mm-hmm.
And so there's lots of reasons, again, too, that OB cases are disproportionately litigated, right? Number one, you have a vulnerable patient that may be injured, and that's the fetus. So there's a long statute of limitations in obstetrics. And again, that varies by state. And some of these injuries may not manifest early on. I mean, just because, a good example of that is just because a baby went for cooling doesn't mean that it has a neurologic injury.
Right.
We've seen lots of outcomes where they're doing great, right?
Mhm.
But they had a high NICU bill that they want to pay for or something. So the emotional states of an obstetric case is really high and large verdicts. And again, dependent on the state, there's some larger than others, but um, they're getting bigger,
Hundreds of millions of dollars.
hundreds of millions of dollars.
Mhm.
And what was the record one was like
The $1 billion baby.
980
Yeah, it was
million,
almost $1 billion.
almost $1 billion in
Yeah.
Utah.
Mhm.
Now, that's insane. So, anyway, let's get back to documentation and
So,
some
I
of the
want you to
things.
comment on the 2 questions of, was standard of care practiced and was
Mhm.
standard of care documented? Like, what's the difference between practicing standard of care and documenting standard of care,
Yeah.
right?
Yeah, I get asked that all the time. And I think for inexperienced experts, they make a big deal about documentation a lot of times. So, for instance, we just did a podcast on policy and that policy and procedures and guidelines that hospitals have, and it may say you're going to assess and document the fetal heart rate every 5 minutes in the second stage of labor, and really, nobody does that. I mean, unless they're documenting with their teeth somehow, I don't know how they do that, right? But that doesn't make it the standard of care. A standard of care is that you're going to continuously assess. And then how frequently do you need to document, right? What is reasonable documentation, let's say in the second stage of labor, just using that example. And everybody has a different way of doing it. And even A1 came out saying that you can have a summary statement of documentation at that time, second stage of labor, because you are at the bedside continuously observing the fetal heart rate and uterine activity and pushing and progress and so on and so forth. So the standard of care to me is an actual doing that assessment, doing it. But the documentation in and of itself does not set the standard of care. But again, I think younger um, expert witnesses really hold in on the documentation. And if the whole case is based around whether a nurse did or didn't document something, then it's probably a pretty weak case, I would say, when you can figure out the facts other ways. And that's through deposition or um, or other documentation, maybe in a particular place.
I think one of the big problems or one of the big challenges that I see in terms of like documentation is blood product administration.
Sure, bugaboo.
I tell you, so it's impossible to
It's
figure
impossible.
out. It's impossible to figure out when blood products were administered, how many total. We
Yeah.
see conflicting notes, conflicting documentation. And that may be because of different periods of time when the documentation was done, but even that's difficult to determine.
Yeah.
I mean, I can count the actual blood product labels from the blood bank, and it will be less than what is said by the clinical team was given to the patient.
Or vice
So,
versa.
or vice versa. So it's very, very, very challenging. Does that mean that they did not practice standard of care? No, not necessarily. But if I look at a record and it says one person says they gave 37 units of blood and, 15 FFP and 22 cryo, and the next one says different numbers, what I know is that patient got a crap load of blood.
Yeah. Lot.
And what I really, since I'm never going to be able to figure out all the details, I'm going to look at other things like when did they start? And what were the vital signs throughout? And you're going to try and do a big clinical picture of, were they making their best effort to adequately manage this patient's hemorrhage, not do the numbers match from one piece of paper to another piece of paper?
And I think a lot of times too, same thing with medications administration. Gone are the days where you have the flow sheet where you knew exactly when it was administered and and you could tell the clinical picture. The EMR, it's the system that makes it difficult
Mhm.
on how, some systems have scanning of blood products, which makes it a little bit easier to where you're scanning it. But then was it administered? I don't know. So it's the timing too of the blood product administration, the timing of medication administration. Sometimes you just can't figure it out from what is produced post delivery from that EMR. And you can't tell the story. So again, I would encourage you to pull a chart in an event. Now, first off, these EMRs, it's going to come out, it's going to spit out about 1,500 pages.
Mhm.
That's on a normal vaginal birth.
Right. It's true. It's
I'm
it's
not
an
kidding you.
insane number of pages that you're looking at.
Insane number. And you're going to get 50 of those pages that probably will say the same thing over and over and over again in different formats. And so I end up as an expert having to put together a timeline that just tells me when things occurred so that I don't have to go back through the 1,500 pages again just to figure out what happened. So in essence, I put together my own flow sheet to find. So then you get down to that blood product administration. It may not or may not be documented on when they started it or when they stopped it. So you don't know how fast it went in. You don't know when they started it. It's insane. That is a huge issue, Stephanie.
Yeah.
Fetal
I think
monitoring can be the same thing.
100%.
You know?
Yeah, and like, for example, very often we're literally having to pull up the fetal heart rate tracing and then trying to superimpose the nursing notes on top of it, what their interpretation is. Now, the tracing might have a vital sign on there, but it doesn't have her interpretation of it. So it's challenging to when you've got an hours and hours and hours long, of monitoring,
Yeah.
to constantly go in and try and figure out, did the nurse correctly interpret the fetal heart rate tracing, in my opinion, or not?
Yeah.
So that's just an example. It's not that the nurse did anything wrong with it. It's just that's an example of how the chart makes it very, very challenging sometimes to try and reconcile
Yeah.
or just all of the documentation that was done. But the things that you need to be documenting, we're going to kind of go through and give you some more specifics about like some pitfalls. So let's get into some pitfalls and issues that can increase your liability when it comes to documenting. And this is just our perspective when we're trying to put together a story and what we see, that works and doesn't work or confuses an expert when we're trying to truly understand. If we're a defense, we want to help you, and so make our job easier. If we're plaintiff, our job is not to help you. Our job is to find the weaknesses in, if there are any, and your job is to make that hard for me.
Yeah.
Tell me a story.
Yeah. Tell the story.
Yes.
So yeah, the first pitfall would be vague clinical impression. I mean, the vagueness to your documentation and the impressions that you're demonstrating in your documentation. So what about some examples like this? Patient appears comfortable.
So that one I have less of an issue with if there's additional information around it.
Right.
Patient appears comfortable sitting in bed, eating lunch, conversing with family, or resting quietly here in conjunction with vital signs and clinical assessment. But when that's all you got, and then we get into deposition and find that the patient was comfortable because she was clinging onto her husband because she was in so much pain.
Well, to me, it's like, what does it actually mean
Mhm.
when someone appears comfortable? I want to know the assessment. So I want to know her vital
Assess.
signs. I want to know.
Yeah.
And same thing if you looked at a fetal strip and somebody said, oh, fetal status reassuring. What's that mean?
It just means they feel the nurse feels good.
I know, right? So it's
What does it
that's just
mean?
so vague and ambiguous, right?
Yeah.
I don't know. And I
Be
don't even know what
specific.
fetal reassuring means.
It means the nurse feels good,
Yeah. Glad you're
or the
reassured.
doctor feels good, whoever wrote that.
But we
So
still see that terminology being written.
100%.
It's insane.
Yep.
Right?
So
Or
what is making you feel reassured? Document that.
right. Right.
Moderate
Be more specific.
variability, absence of decelerations.
Yeah. I mean, and
Whatever.
this occurs all the time. The
Mhm.
question about your documentation about
Mhm.
what made you reassured at that moment always comes up in a category 2 strip.
Mhm. Yeah.
What made you reassured that in this category 2 strip, you continued Pitocin? She had a
Yeah.
normal baseline rate. She had moderate variability. She had no recurrent decelerations. Example. I mean, that's what supports your documentation, not that you feel good about it. Right.
So the vague impression, that's one. Missing notes. Okay. Like there's a difference between if it wasn't documented, it wasn't done. We've talked a little bit about that.
Yeah.
But you have to have something.
Something.
You have to have something. You communicated to, let's say you're the nurse at the bedside, you called the physician or the midwife and communicated your concerns, but didn't document it.
It comes up a lot.
A lot.
And then nurse at deposition is going to say, well, I'm sure I did. It's my normal practice too. Why didn't you document it? I mean, the only answer to that is I don't know. Right.
Especially if you documented a call earlier, but then didn't document this call.
Right.
So now we've got inconsistent. So we then have to decide what we believe.
Right. Right. Inconsistency comes up a lot. That's another pitfall for nurses and physicians.
Mm-hmm.
Again, that category 2 strip. And maybe the nurse writes all the components even down for a category 2 strip, but doesn't necessarily document the category because, I mean, who cares? If you document the categories, it's meaningless, right? And if you are going to document the categories, make sure that you have the right category. Because I've seen that too, where it's actually a category 2 and the nurse documents category 1. It's just another way to make an error in your documentation. So just the essential components of the fetal monitor strip is what you should be documenting versus a category 2, because category 2 tells me nothing. And maybe I've documented components that would equal a category 2 strip, but then the physician turns around and writes that it's a category 1. There's your inconsistency in just that one note. Because we're comparing again, here's when the nurse documented, and then here's where the physician documented. And they're inconsistent. So what was the communication back and forth between the two over the differences, right? Same thing between a category 2 and a category 3. I mean,
yep,
that can happen too. And
then,
so,
but it also can be inconsistent, like timing.
Oh,
happens. Or but like, are they at the bedside or are they not at the bedside? On the unit is not at the bedside.
Right. Well, timing comes up a lot for various reasons. One, where are you getting your time? What time is it? It's not the time on your watch. It's not the time on the wall. A lot of times those can differ. It should be the time on your monitor because that's what you're basing. Everybody's using the same thing in the room to tell the time, because 2 minutes, 4 minutes can make a huge difference in a legal case. And if everybody's using an inconsistent time management or time source, then it can differ by minutes. And that happens a lot, actually. Yeah.
And if sometimes it's not, we're going to talk about late entries in a minute, but like it's just because the timing. So let's say you call a physician and you report a concern, but then you have to do a clinical care of some sort. Okay. The patient needs assistance, whatever. There's the million things. You document as soon as you are able. And if a significant amount of time has passed, you're going to document the time that the call was made, even if your documentation is 45 minutes later.
Yeah. So that's your next pitfall is your late entries and amendments.
Yes. They kind of all feed because they're all related, but Before we move on to late entries, I wanted to comment, it's not unusual to have discrepancies in who was present
Yes.
and challenges trying to understand who was present. And you don't ever want to get into the situation where you're having to get to deposition to understand who was physically present.
Mm-hmm.
So document. Like if you're the nurse, you document when the nurse or when the physician or the midwife comes in, when your charge nurse comes in, you document those things. If you're the physician, you're going to document, this was the time I arrived at the bedside. And, that can eliminate that confusion. Now, if there's discrepancies when doc says I arrived at midnight and the nurse says I arrived at 1 a.m., that's a different problem.
Yeah. We used to always write it on the fetal strip.
Yeah.
You could tell too, because it was a certain angle in which the nurse could write it on the strip, right?
If it's happening in real time, right?
Yeah, but a lot of units don't even run paper anymore. So there goes that note taking.
I think that's pretty common.
It's very common, right? So there goes that timing to where you could recreate your note after the emergent event. Because, let's face it, patient care comes before documentation.
Yeah. And in units that run the pink strip, if let's say you've got a traveler nurse or you've got a new nurse, like they have to understand how documentation happens. And you could have a new nurse that worked at one facility where they documented on the strip all the time. And then at the end of the shift went back into the chart and did it. And they think that's how it happens there at this facility. You just, there's those kind of conversations are important.
Right.
So, and that kind of feeds us right into late entries and amendments.
Yeah. Again, if something's happened and the outcome, one of the issues in your deposition or in a case will be that you went back and wrote everything down and kind of in a CYA manner. And I've seen that. I had one case, for example, that the nurse didn't document anything her entire shift. And it went in the next day, and this came out in deposition. Went in the next day and documented everything and blamed the patient in her documentation. Blamed the patient. She couldn't sit still. She wasn't sitting still. She kept removing the monitors. She wouldn't lay back in the bed.
Because she was anxious?
Well, she should have been anxious because her uterus was rupturing. Okay. And she was having an abruption. And they didn't document anything but blame the patient. And so there's two things in that example. Number one, the nurse didn't document anything during her shift. That's not acceptable. And in deposition, she came out and said that she was too busy to take care of the patient. So again, deposition tells a lot of things that you might not want to come out, but they came out. And then she was asked the next day after they found out what happened to the patient who went to another hospital, that she had to come in and document something. And then when she came in and documented something, it was from memory, and then she blamed the patient. So lots of issues about that late entry or entry. So I'm going to know as an expert when you document something. And why is that?
Yeah, the EHR does not allow you to hide any of that. Everything is time-stamped.
Right.
We can, in fact, sometimes it's challenging to go in and understand, is that a timestamp of when they ratified it or finalized it or when they actually went in? But there's timestamps on everything. So if you go back and look at the chart afterwards, they're going to know. They know everybody that accesses the chart anytime they can request. It's called the metadata. So they can request some metadata, and they will, so that they can see who did what, when, and how you documented. I've seen notes completely crossed through electronically, deleted, and rewritten. And sometimes it's to clarify or add, and it's a valid correction. I thought I was documenting on one patient. This was the wrong patient. I was in the wrong chart. That those things happen. But when the entire chart is that's a different signal to people who are reviewing the chart. So there are no secrets when it comes to when your note was written.
Yeah, I think the issue for late entries and amendments becomes, well, how late is it okay to write something? you
Mhm.
know? And again, sometimes care dictates that.
Mhm.
And I think it will come down to what's reasonable based upon what was going on.
And you can
Right.
write that. You can
Yeah.
say, you know, in a code situation, you have to have somebody, keeping track of all the actions in a code, a recorder of some sort. But if you're the nurse administering the meds and doing all the things, you're not going to have time to document until someone takes over your tasks or your
Right.
shift or that event is closed because you've got to put the care takes priority over the documentation. And you
Right.
can say that. You can say documentation, you know, this is a summary of events, whatever it may be. You can write that summary right after the event. I've done that many, many times.
Right. And I think doctors are actually better at doing that than nurses. The nurses feel like they have to have and you need to have as specific as possible, but they've never been trained to write that summary note.
Mm,
Right.
mm,
So a lot of times it's just missing and you
mm-hmm,
can't figure it out because they don't have a summary note
mm-hmm,
to write. But I think it's pretty well understood by everyone at this point that late documentation is going to occur during an emergency because care is care trumps the documentation for sure.
right.
But how late is late, and that has to be reasonable based upon what's going on with the patient, and that you need help with that time out to be able to get to your documentation.
I think what's harder to understand in hindsight is when there's very little documentation and it wasn't an emergency. Like, what are we doing?
Right. You've seen people do that. They wait
Absolutely.
until the end of their shift to write everything
Yes.
down, and that's just wrong.
Right.
And from a nursing perspective, we're asking to be one-on-one with patients, but yet we're not documenting.
Mhm.
And where can you document? I always make it a habit of when I was in nursing, staff nursing, I would stay at this bedside and do my documentation. So if I came out of the room, my documentation was done. I'm
Mhm.
caught up.
Mhm.
Not rip the strip off and come sit at the nurse's station and write it all down then. I
Mhm.
just do it there in the room. But anyway,
So, a couple of other pitfalls, consent. Now, we have a whole
yeah,
podcast on this. Consent is not a piece of paper. This is it's basically documentation proof that a conversation took place that discussed the risk, benefits, and alternatives. In emergency situations, there are ways to do this. Your hospital will have their opinions on how these things are handled as well. You'll have to figure out how to handle when there's language barriers, when they're not able to consent. But the key is the conversation about risk, benefits, and alternatives that is happening with the person who is responsible for making the decision. Typically, that is the patient. Sometimes it is not. Um, so I think there's a whole podcast we have on that one. And I think the last one is, um, we call it the non-action, like not just documenting what you did, but what was your differential and what did you consider doing and what did you
yeah,
not do and why? For example, why did we not do a cesarean? Why did we not proceed with inducing a patient with preeclampsia? Or ruptured membranes? Like, why are we choosing the non-action route? Because a non-action is an action.
right. Right. I think that this is really impactful for both nurses and physicians. And I could still go back to that plan of care is that we are agreeing to this plan. The patient is agreeing to this plan and the rationale as to why. I call this down home charting because it tells the story of why you're not moving in a certain direction.
Mhm.
We see this a lot for physicians in the operative vaginal birth. Let's say you just chose to go to an operative vaginal birth versus a cesarean section. Why? What
Mhm.
what was your decision making? What was your rationale?
Mhm.
It could be that the patient refused a C-section.
Right?
But if that's not in the chart, you don't know that until deposition.
And this, in my opinion, this kind of documentation is best made prior to the intervention, if possible. It may
Possible.
not be possible, but if let's say it's a patient's reached her limit of hours of recommended pushing in the second stage. And now we're like, okay, are we making progress or is it time for a cesarean? And you're going to have a conversation with the patient about the risks, benefits, and alternatives of continuing to push, doing an operative vaginal birth or cesarean. If it's not an emergency situation, that conversation can be had and documented. Okay.
Yeah.
Instead of you have the conversation or you don't, the birth happens, there's an event, and now we're documenting that 2 hours ago we had a conversation with a patient and they said they didn't want the other intervention. Right? Am I making myself clear there?
Yeah. Yeah.
So
no.
They
you are.
decline the cesarean. We
Yeah.
continue to push. We have an injury. And after the fact, we're documenting why they declined the cesarean. It's not that it's wrong. It's not that the patient did something wrong. The physician did something wrong. The nurse did something wrong. It invites further scrutiny and further questioning to understand what really happened. And in deposition, people sometimes say the absolute right thing that's hard to argue with, and it's all consistent with patient, physician, and nurse. And sometimes it's not. Usually it's not.
I know, exactly.
Or it wouldn't be in the stage where we're reviewing it.
I know. So some of our takeaways today. So like, if you were to read aloud your documentation in a courtroom, would it reflect the care that you provided? That's the takeaway from me. And if it's your system that is inhibiting you from reflecting the care that you provide, change it. These systems you can adapt to meet your needs. And then the last thing I would say is chart what's important. And especially if you're in an emergency or a time crunch, I really don't care about our body image at that point, right? I care about how you manage that hemorrhage. I care about when you called the doctor and what you said to the doctor or the midwife. I care about that y'all have everybody's agreed upon the plan of care. That's the important guts. Yeah, I want the guts.
Yeah.
Would you add to that, Stephanie, your takeaway?
Yeah. I mean, I think the chart is really what's going to speak for you when others are reviewing it, trying to decide if you did something wrong.
Yeah.
That's your voice. So
right.
Make sure you document what you were doing. And it doesn't have to be minute to minute, all the things that we've said, but someone should be able to look at the chart and understand what care you were providing for the patient and why. And if you wonder if that's the case, just pull a chart on a patient that didn't have a bad outcome, as far as you know, and pull that chart and look at your notes critically now with a different eye. Like you're a plaintiff's attorney and a patient has claimed that something bad happened. Are you happy with your documentation?
Yeah.
How can that inform your future notes?
Yeah. I mean, I think that should be the assignment for everybody, is to go back and have a chart printed out and look at it, do a chart audit. Chart audits are pretty powerful when you start looking at the way others might even document in the same or similar circumstance. So you would learn from that opportunity to say, how would I do this? And, oh man, I really like the way they wrote this, because or what's missing, those types of things. So I really think it's a powerful tool to be able to learn from documentation.
Well, thanks for listening, everybody. Hopefully you guys got some clinical pearls out of this and can take this back to the bedside, but share your thoughts and your feedback. Are there things that we missed that you think are tips people need to know, or what's your experience been? Have you ever been, in a deposition or in a situation where you regretted your documentation or lack thereof and wished you'd known some things going in? So, what are your learning tips? But we appreciate all you guys. If you want more of this kind of content and more medical legal content, you can find us at patreon.com/CCOB. Our website is clinicalconceptsinob.com. You can check out the Critical Care Obstetrics Academy and all of our online learning platforms, and find us on social media at all the platforms, Instagram, LinkedIn, Facebook, etc. Thanks for listening.
Thanks, y'all.